We'll get started, everyone. Thank you for coming. Before I begin, I'd like to acknowledge our country. So I'd like to acknowledge the traditional custodians on which I'm joining you on today, the Whadjuk people of the Noongar Nation, and pay my respects to both elders past and present. It's a real honour and privilege to do the work that I do on this land and extend our acknowledgement to the many countries of the people who are dialing in with us today, because we've got people not just around WA but across Australia as well. I will double check though people can hear me and hear me clearly and that there's no IT issues. Yep, Drew's giving me a thumbs up. I'll take that as full endorsement. Sorry, I haven't introduced myself. My name is Stephen. For those of you who I haven't had a chance to meet yet, I'm the Syphilis Senior Program Officer at WA Department of Health in the Sexual Health and Vulnerable Virus program, and I also coordinate the Syphilis Point of Care Testing program, which is why we're all here today to discuss the program and the upcoming changes here. To do a bit of housekeeping, you will note that I have started recording the session. So for those of you who aren't familiar with our Syphilis video conference series, we host them as these lunch and learns, but they get recorded and hosted on the WA SORG website as well for future viewing and upskilling as well. So just to note that this is going on the internet, so what you say in the room might be on the internet forever. I will note as well that this that we're talking about just the WA Syphilis Point of Care Testing program today. I think there's quite a number of people who are involved in the NACHO or the national program. So I do want to highlight that the changes to the program are just relevant for the WA Department of Health Syphilis Point of Care Testing program. However, there is information here that the findings from our evaluation of the WA program that might be useful for those of you who are in the national program. I do note that Nacho, Amelia and Emma are in the room, but if you've got any questions about the national program, please take it up outside of the session. Oh, Emma's got her camera on, giving a little wave. Yep. Yes. How the session will kind of run today. Oh, and there's Amelia as well. Hi. How the session will run today is I'll go through the kind of WA Syphilis Point of Care Testing program, the findings of our evaluation and what changes are being made effective July 1st. I think a lot of you have received the communication, the kind of 2-page with the information and the Q&A, but we'll go through the changes in much more depth today, and then there'll be a session at the end where we will go through we won't go through anything, but there'll be a chance for people to ask questions, have discussions as well. We'll just see how long that takes. But throughout the session, I'm really happy for you to raise your hand and ask a question or pop something in the chat. We've got Rudy monitoring that. So if you want to ask a question in real time, please feel free to do that during the session, but there will be a session at the end to have those larger discussions and implications as well. I think that was all my housekeeping, but if we have anything along the way, I'm sure we'll address it. Cool. I'll just get started then. So the WA Point of Care Testing program, here's a bit of an overview for those who aren't aware. So us at Communicable Disease Control and WA Department of Health coordinate the program. So we look after the enrolments, we do the ordering of point of care testing supplies, and we also look after the reporting and cleaning of the reporting data as well. We've got Flinders. So they look after the quality control, quality assurance of the program and all the training, and obviously the enrolled health services. So many of you in the room who complete the quality requirements, you're the ones out there doing the testing of people, reporting the data and managing the stock as well. I also want to note that we do have a hub and spoke model for those who aren't aware. So a hub is a testing site that looks after the clinical governance of its own clinic, and it might have additional spokes. So those are additional testing sites that fall under that hub's clinical governance. So you can see the map on the screen shows all the sites in the WA program, so not the NACHO program, the WA program. So any dots that are a single black dot, that is a hub by itself, and if you see a large coloured dot with a bunch of small little dots around it, those are the big dots, the hub, and the little dots are the spokes. How it works is quite different for every health service. You can see up in Kimberley, they've got one hub and they've got about 6 or 7 spokes underneath them. There's a site in Perth Metro for which they've got the hub in Perth Metro, and then they've got a spoke down in the southwest. So it's all different for all the different services that we've got enrolled in the program. I just also want to go through the data that we collect for the syphilis point of care testing program, because I don't think many people get a chance to see the testing numbers and the progression across the lifespan of the program. So the program's been active since July 2020. So we'll go through the data collected from Q4 2020 up until Q4 2023. So you can see here the number of point of care tests by quarter. So total since Q4 2020 to Q4 2023, the program's done 5,306 client tests over that time, of which 239 were reactive, so 4.5%. That's a really great finding, considering that's just under 10 times the test positivity rate of traditional syphilis serology. So obviously we're testing the right people. We can see an overall trend of increasing point of care tests by quarter over time. However, I will note the large increase in Q2 2023. Well, that's largely due to Boolaloo Public Health Unit, formerly MCDC, doing their surge testing in the metro area. I think largely due to that kind of large number there. So, but overall, we're seeing an increase of testing over quarters, but we have seen a drop over the last two. When we looked at Aboriginality, about 70% of tests were done on someone who identified as Aboriginal in the program. They also accounted for quite a high percentage of reactives in the program as well. When we looked at gender, about 50% of the point of care tests were done on someone who identified as male, and about 40% on women or females. This is quite interesting as well, considering when we look at our typical syphilis serology numbers, testing in men is less than half testing of women. So it's quite interesting to see men are overrepresented in point of care tests as well. Across age groups, the 40+ age group was by far the largest represented age group. And we believe this is just largely due to that's quite a large and wide age group compared to the other age groups, which are done those kind of 5-year allotments. However, the highest reactive percentages were in the 15 to 19-year-olds and in the 35 and 39-year-olds. And when we look at it across region, the Metropolitan and Kimberley were the highest number of client tests in the program. This makes sense. They have the most testing sites anywhere across the state, but I will note that the Pilbara does have the highest reactivity rate at 11.3%. And then we looked at it by service type. I think this is really interesting and good to look at, particularly one of the main differences from our program to the NACHO program is that the NACHO program only has AMSs or ARCHOs enrolled in the program, whereas our program allows any health service provider to join up. So that's a key difference we need to look at. So overwhelmingly, a large number of tests were done by a public health or government health service, followed by an ARCHO or an ARCHO. However, I do want to note the Department of Justice, while they're the third highest testing out of service type, they only have one testing site compared to the other types which have multiple testing sites. The fact that they've only got one, there's one testing site and they're doing all those tests, I think is pretty impressive. That's all I had in terms of the point of care testing data and what we've collected over the last 4 years. Before I move on, did anyone have any questions about the data they wanted to raise?
I was just wondering what the one place is in the Department of Justice, where that's located, just out of interest.
Hi, Marissa. It's in the Kimberley.
Okay, thank you.
Any other questions? Cool. So now I'll just go through the findings of our point of care testing evaluation. I do want to highlight the evaluation period is only from July 2020 to September 2022. So it's not the entire lifetime of the program so far. It's only for the first 2 or so years. So I do want to note the sample size for the number of point of care tests is just over 2,000 client tests and just over 100 reactive point of care tests as well. So how we did that, we used a mixed methods approach. So we used qualitative data that was collected through a survey sent to currently enrolled services in September 2022, and we did the quantitative data comes from the data collected through enrolled services as part of their reporting, through contract reports, through the invoicing, through the suppliers, as well as case detection and through the wanted system as well. We combined these together to form the findings and then to implement the upcoming changes into the program as well. So we looked at, first off, there's 119 reactive tests over the evaluation period, and we wanted to determine what was the true number of new cases detected in the program and how many were historic. So we did this by doing an audit, comparing the demographical data that was applied at time of reporting to the data that's collected in wanted. And we were able to determine 45% of reactives in the program detected a new syphilis infection, and 20% was a historical infection. Unfortunately, just over a third, we weren't able to determine if they were a new or historical infection. That's just due to because of how the data gets reported to us from a service. We weren't able to determine if that person was in wanted or not. But I think showing that about 50% of the reactives in the program are detecting a new infection, I think that's a really, really good finding for the program so far. And then when we looked at case detection and comparing that to reduced days of infectivity in community, we looked at the new case detections across all the regions. We compared that to the median days to wait for a serology result over the time period, to then do a calculations to look at the days of reduced infectivity, and it came up through over just the evaluation period. We've saved over 200 days of infectivity for someone who's infectious with syphilis in community. Again, that's a really, really great finding, and I'm really keen to kind of do this analysis again, because if we do that same calculation on our current reactives, so if we've got 239 reactives, if 45% of those are new case detections, that means we've got 108 new case detections through the program. Using a 4-day median return on serology, that's 430 days of reduced infectivity in community, which I think is just massive. That's a year and 3 or 4 months. That's massive. Also, I want to note in terms of the case detection of new syphilis infections, that wasn't, when we looked at it across the different age groups as well, there was case detections across all age groups. So I think that's really important to highlight. It wasn't just that the younger age groups were overrepresenting in the new case detections. The older population was also having just a comparable number of new detections of syphilis in the program as well. So it is showing that it's useful not just for young people, but it's also useful for people who are older as well. Next component of the quantitative analysis was looking at service performance. So we wanted to look at number of point of care tests used by services for client testing, along with the reactivity rate and how long it took for services to begin doing point of care testing for clients from when they signed up. And so then we've got up here the top 3 performing services based on percentage used for client testing and startup time compared to the bottom 5 services and the average across all services signed up in the lifetime of the program over just the evaluation period. I do want to highlight. And so I suppose there's two kind of things that stand out to me here. Certainly the percentage of point of care tests used for client testing. The average across the program was only 14% of tests were used for client testing, which is very, very, very small. And even in our top performing services, it was they only used half their tests for client testing. Now I do want to highlight that does not mean that the other percentages of tests did go to waste. Tests are used for upskilling new staff members. They're also used for the quality control, quality assurance requirements. But I suppose looking at it from my perspective, even if a service is working efficiently and no tests are going to waste or going straight into the bin, only using half the tests for client testing is still rings alarm bells for me, because I know that doesn't suggest that we're not using them as efficiently as we can. But certainly we know from reporting from services that we do know a number of tests have gone to waste or have been thrown out because they have expired over the lifetime of the program as well. And then looking at the average startup time, there's a massive discrepancy there. In our top performing services, they implemented client testing quite quickly from enrolment at 2 months. But on average, services took 8 months between enrolment to then beginning client testing, which again is a massive wait, particularly when we consider the lifetime of the stock. The point of care testing strips are only really viable for 6, 7, 8 months. And so if you're signing up, you're getting an order very quickly. If you're not doing client testing straight away, they might expire and then you've got to do a new order for testing strips before you can do client testing. So you've already kind of wasted potentially a first batch in there as well.
Does it take long to get the products to the services once they order them?
No, so I think I'm happy for a service to jump in as well, but my understanding it's less than a week, even for the regional remote crew. As soon as we put the order in, it actually gets dispatched and sent off quite quickly. I'm happy if someone in the room wants to confirm their wait times, particularly from the regional folks in the room. If you've got like a wait time when you email us to say get us stock and how long it takes to get to you.
Yeah. Hi, Stephen, it's Aggie up in the Kimberley. Look, I'm always very surprised it's really quick. So generally about a week, not much more.
Yeah, so that is good. The turnaround time is quick. I do note we are the suppliers are having issues with the 30 pack, so they're taking a bit longer because they've been out of stock. But if they're in stock, it's quite quick. Tanya, sorry, I saw your hand come up quickly.
That's all right. I was just going to say it took 2 days after I ordered them, sent you the email, so it was perfect.
Yeah, and so Tanya works in Metro Perth, so that's incredibly quick. Sorry, any other comments or questions before I move on about the kind of quantitative findings of the evaluation?
Marissa.
Hi, Marissa.
Actually, I think this is going to be covered in the thematic map. I was just interested to know what was different about the structure or the systems in the top 5 and the bottom 5. But I think that's, I'm looking at this, I think you're going to explain it all, so I'll shut up. Sorry.
Yeah, we'll go through it now, but you will certainly see, I think, what the differences are in services that were performing well or perceived to be performing well, at least compared to those who felt like they had areas to improve in. Yeah, so as I mentioned in the qualitative component, we did a survey of all currently enrolled services, and of the 21 services that were enrolled at the time, 11 responded. And from their responses, we were able to generate these 7 themes that were then grouped into these benefits, barriers, and enablers of point of care testing in a program. So I'll go through them now with you as well. So in regards to the benefits of point of care testing, the first one was the testing at-risk people or people who otherwise would have not consented to a syphilis serology. There was a whole range of different priority groups that services noted that they could test with point of care testing who otherwise wouldn't, or maybe would have not consented to a traditional serology. So this includes Aboriginal people, young people, sex workers, homeless people, pregnant women, women of childbearing age, clients who are needle phobic or who use intravenous drugs, all different types of cohorts or target populations noted of getting a point of care test. I think it's really great to see the wide birth and reach of point of care testing. The second theme, these immediate results and treatment, that's a bit of a well-dar kind of finding. Like obviously we get the test results within 15 minutes of putting the droplets on there, so it's a bit of a like, yeah, we know that kind of comes up with immediate result. But what was quite interesting with the findings for this theme was this idea of actually showing the result. So services talked about when they had the test strip in front of them, particularly when it was a reactive point of care testing strip, being able to actually show the person in front of them, hey, this is double lines, you've shown you to be reactive to syphilis. This means, we're going to have to do a serology and give you treatment, was actually really, really useful. They talked about it really changing the dynamic for the client. It made them take their health much more seriously and take their results much more seriously as well. And I think that's a really interesting finding, particularly when we think about how we engage with clients. I think about when I go to the doctor, I very rarely see the results on the page. I get told the results, the interpretation. I think kind of showing them the results really kind of changes that dynamic. I think that's quite interesting to see how that's used. and maybe changes not just the way we talk about syphilis or how we use point of care testing, but maybe other diseases or other results from serology or other tests as well. When it comes to the barriers, so the biggest one was this, the point of care testing program was extra work for enrolled services. And this would kind of get split up into what was extra work purely from the program and what was extra work from a reactive or positive serology result. So we can see that top quote there. A lot of services really highlighted that the quality control, quality assurance stuff was really time consuming for them. You know, I know it takes about 15 minutes to get a result, but the kind of setting up the space, going in there, doing it, then reporting it as part of your monthly or quarterly reporting, doing it every time you do outreach, doing it every time you think the tests are compromised. It was kind of just adding up time after time after time after time. And when you are such, when you don't have a lot of time and you're maybe working in the clinic, you don't have 15 minutes to spare, this was seen as quite burdensome. And then that second kind of section talking about when there is a reactive result, the burden as of following it up, confirming that it's a new infection or a previous infection was seen as a lot of work. But I suppose I do know, I suppose it's to separate these out, that kind of top quote really highlights the burden or the extra work to do just with the program at the moment, whereas the other one, that's work a clinician would have to do if they had a positive serology result anyway, following up if it's a previous infection or what's the treatment history there as well. So I suppose it's the kind of what's true burden in the program versus what's kind of a reactive or positive serology result. The second barrier was highlighted was this training of staff. So because staff members, because operators need to be trained up to do a point of care testing, it was a massive barrier to actually get services involved or having enough staff to be able to maintain a program. Trying to book people into a training when it's can be really, really difficult. If you've got a high staff turnover or relying on locum staff, which is particularly relevant for regional remote folks as well, it was a real barrier having to do training to be able to get them to a point of care test and to be able to maintain a program in your service.
Oh, sorry, to jump in, Donna just made a comment saying that they always show patients their test result on the computer screen because they would want to see them if they were a patient.
Oh, thank you, Donna. So that Donna's the public health physician here, but also works at the M Clinic. So that's cool to see that Donna does that. The next three things regarding the kind of enablers to point of care testing. So services really talked about the importance of really embedding point of care testing into their service delivery or into their BAU. And I think this makes sense. I think a lot of services in the lifetime of the program have signed up, you know, have got their staff trained, have ordered stock, have had every intent to do point of care testing, but then haven't thought about also how we're going to actually do this. You know, and it's some of the stuff about changing policy and procedure. It's about thinking about who you're going to test. Are you going to be testing everyone through the door? Are you going to be testing people who are from certain target populations and demographics? Are you going to be testing people who get an STI test? You're going to offer this additionally. Even that kind of practical stuff, like the quote down the bottom, having it in the pathology room. So while you're doing the blood draw for other stuff, the point of care test there is there, good to go. So it's about really kind of considering not just using point, like it's not just kind of signing up to the program and getting the test, it's actually really considering what are you going to do now and how you're going to utilize it and how you're going to make sure it's working efficiently. And that really links into the next thing about passionate staff and staff champions. Services really talks about the importance of having at least one person in your service who's really passionate about point of care testing, who really leads the charge, who does that work in embedding it into your service delivery. That was really, really important. And so obviously, again, people talked about kind of the issues when they have lost a champion or when they have such a high staff turnover, they don't have a champion on the side, how that really stalls or really negatively impacts the program as well. So it's really important to have a staff champion, have someone who takes the lead and not assuming that it's just kind of got to get done as part of a BAU, because it ultimately, a lot of services reported that it didn't get done and they need someone to really take the reins and take the lead on it. Finally, staff ability to opportunities that we test. So this is really important. So it wasn't just staff being trained to do a point of care test, but actually having conversations and yarns about sexual health or broaching the conversation with someone in front of you to how to even start the conversation, or you know, building that kind of confidence and opportunity to do a point of care test was really, really important and an important enabler for point of care testing. Yeah, that's the findings of the evaluation that we went through there. Were there any questions, or Marissa, I suppose, does that answer your question about kind of what was the kind of the structural differences between a top performer and a lower performer, or did anyone else have any questions or comments?
I was just thinking, did that correlate? Could you look at the themes in relation to that? Did you do that, or was that you didn't want to identify things that much?
Yeah, we did it internally. We won't present it here because it does identify services given kind of how they work, and they might talk about where they're located. So we won't present it here, but certainly the team did look at it internally and looking at those kind of top performing services and how they responded to the survey and what they were saying. So yep.
Is there a feedback process there which happens like when you're doing it and then you get the feedback that you are picking it up, it gets exciting and you want to do it more sort of thing? Is it like a critical mass of tests and then results?
So I'm not sure what you're asking, Marissa.
But I was doing a test and I got positives on people that maybe I wouldn't have thought about, like, you know, a 50-year-old. Then you kind of think, wow, you know, I can't make assumptions that certain people of certain ages are not going to be positive, and I'm going to try and do it a little bit more proactively. You sort of get that feedback. Is that something that might happen, or it's pretty irrelevant? I don't know.
And that's really a good question for the room as the people who are doing the point of care testing and wondering if that is something that's happened to them or a staff member that they've kind of had their assumptions checked, or maybe have found that it's kind of been really motivating. Has anyone in the room want to feed that back? I will pass on to the room as someone who doesn't do point of care testing. I can't comment on. Yeah, I can see Amy and someone else has their hand up. But Amy, you can go first.
Oh, I was just going to say, I think we try not to make any assumptions. We offer it to every client that comes to our clinic, and we've had people as old as 70 with positive syphilis results here.
Thanks, Amy. And did someone else have their hand up? Thomas?
Hi there. I'm just going back to our one from last year. I think we had a thing with the Flinders mob. We actually had a female pregnancy that come back twice positive on the point of care testing, but negative in serology.
Yep, so that was probably an example of a test. I can't remember what the outcome of that test result was. I think, Matt, you're involved in the investigation for that. Or Thomas, do you remember what the outcome for that was?
Well, I know after the first time, I think she got treated, but yeah, but her serology, like the 2 times beforehand, like everything was come back negative, but the point of care testing kept on coming back positive. But it turned out her partner was positive as well, so which was a good thing, but because we got managed, he got treated as well. But yeah, we just kind of found that funny, just having the 2 positive cases that weren't positive.
Yes, that is interesting. So I can see who's got their hand up first, or Mary Kate, I think you were next.
Hi all. Yeah, we did have a positive point of care test through Geraldton Regional Hospital Emergency Department. So they were able to commence treatment, and I think it did motivate and encourage the staff to see that the value of point of care testing through ED. I think up until then they were a bit perhaps blasé about it, but seeing they did find this positive test, I think it did pique their interest and their enthusiasm quite a bit more.
Thanks, Mary Kate. And that's great to hear. I think that's what Marissa's asking, right? You get one reactive and it kind of really motivates you to kind of continue testing, or it actually is useful. It does detect new cases. Yeah.
There's just sorry to jump in again. There's just a comment here from Tanya saying that when you're talking to other people, other staff members in your services about doing the test, just to let them know not to make assumptions.
Yeah.
Tanya.
Yeah. Oh. Thanks everyone. I've got up on the screen here the current requirements for the Syphilis point of care testing program here, and I've done a beautiful colour code of responsible parties. So blue you can see is the enrolled point of care testing service, yellow is Flinders, purple, or the I think it's purple is WA Department of Health, and green is your local public health unit. This is the current requirements. I do want to highlight, I won't go through them all because I think lots of people are aware of what the requirements are, but I suppose I do want to note the large amount of blue in here. I think that's reflected, as we talked about, in the qualitative findings, that there is a high burden on the enrolled service to do a lot to be part of the program, and it can be quite burdensome, particularly when you've probably got 20,000 other things you need to be doing in one day alone. To add this to your workload can be a lot. So what we're doing is really reducing the burden for services. So as noted in the communication, moving forward from July 1st, we will not have the QC EQA requirements that are offered through Flinders University. So that'll be changing to look at other aspects of the program to ensure the quality of the tests. So doing things like, for when you do a point of care test, requesting a serology where possible. Obviously for a reactive, it's required to do a serology as well. Ensuring your staff are adequately skilled to do the test. And for a reactive test as well, now that we've got the syphilis red cap, we can be looking up people's previous testing history in their quite easily as well when you contact your local public health unit moving forward. So I think this will create a lot of efficiencies, moving away from the kind of additional quality control testing to this kind of more business as usual quality assurance. I think will be less, well, it is going to be less burdensome on the enrolled services because they won't have to do all that additional testing. When it comes to the training of staff, so obviously previously Flinders completed the training for operators. Moving forward, we're going to be allowing services to determine the appropriate level of upskilling for their staff, because I do know it is quite a simple test. There are some services for which they might just be taking new staff members into a room and doing a demo for a point of care test and how it works and what to do when you get a reactive in their space, and that's totally fine. For other services who want to get kind of more formalised training, or maybe who are new and don't have the expertise in-house on how to do a point of care test, Abbott's, the suppliers of the point of care test, have provided us with a PowerPoint that we can send to services. So staff members can do that, can go through the PowerPoint in their own time. And then there's a competency quiz at the end you can complete. Individuals in a service can go through this PowerPoint with another staff member and talk through it as well. Abbott's are also happy to do the training over Teams as well. If you do want to have someone in the room who is external, you can ask all those you can ask those questions about too as well. And they're pretty flexible. The training, they said, takes about 30 minutes, give or take kind of question time as well. So it's quite flexible for services as well. We're also encouraging services to also seek other upskilling for staff as well. So noting that kind of ability to opportunistically test. So not just doing the syphilis point of care testing, but looking at other trainings and ways to upskill staff, like the first BBVs, the Ashland online training, speaking to your local public health unit about what trainings they offer around syphilis as well. All these kind of things to help build that staff confidence and ability to point of care test, as well as some other changes that are happening in the program. In regards to embedding point of care testing and those staff champions, so we're going to be requiring services to really kind of name up a staff champion, and we're going to be calling them that to really kind of help push this idea that they are a champion for syphilis point of care testing in their program. And we also would encourage services to even think about putting it as part of someone's JDF. So if that person leaves and someone else new comes into a role, that JDF, that their role is looking after point of care testing. We've also added some additional questions in the enrolment form and information about how to embed point of care testing into your service delivery, and actually really consider what you need to do and how you're going to use it, and start thinking about those kind of processes before you even sign up, because I think this is really, really important to consider before you sign up, is that actually, well, what are you going to do, how are you going to use it as well. The current maintenance of the program. So this is the current maintenance, again, colour coding it based on who's responsible for it. This will be changing slightly as well. So to help encourage client testing. Moving forward after the 1st of July, we're going to be asking services to purchase their own stock through the supplier. We're happy to show you the instructions on how to do that. When services use all that stuff up from that invoice or from that order, they will send us the invoice for it, and then at reporting time, if we can see you've used 80% or a predetermined kind of benchmark percentage for client testing, the WA Department of Health will reimburse you for that stock. And if you've shown consistent high client percentage, we'll move into the old model, which was that we would just purchase the stock from you as you send the orders to us, if you so wish to do that. And the other thing we'll be looking at as well is doing that kind of investigation of the number of new infections in the program, so which is not something we've done consistently, but something I think is a key outcome of this program, and something we need to look at how we're kind of quantifying that. Sorry, Rudy.
Sorry, there was a question that I missed. Apologies, Tanya. Just going back to the training.
Yeah.
Tanya's asked if the services sign off on the training, and do new testers need to be registered anywhere like they are with blenders?
No, so there's no need to kind of register a new operator anyway. Through the Abbott's training, you can get, like I said, there's a quiz at the end, and then you get a certificate for completion. If you want to keep that for your own records, that's totally fine for a services internal records for their staff PD. I'm not going to be tracking who's an operator because, I mean, ultimately, anyone in your service could be doing a point of care tests, and I might not know about if they're operator or not. I'm kind of putting the onus back on services to, I suppose, consider their own governance, consider their own internal point of care testing programs, and how it's best utilised. And if you want to get extra training from services, this is one way you can go about it. So no, we won't be monitoring who's a trained operator from our perspective. But great question.
And Donna made another comment just saying that the PowerPoint and the quiz is very good, and Donna got the certificate of completion, and it took about half an hour, 30 minutes.
Yeah, thanks.
So
yeah,
great.
I think that was okay. Yeah. If you are interested, or if you're currently enrolled and do want to continue the program, we do need you to fill out the new enrolment form that is pending approvals. It should be out the next week or so, and I'll distribute that to everyone in the room. We'd love you to have a chat to the point of care testing program, particularly if looking at the kind of requirements or responsibilities that I've set out here. If it's something that you think your service might not meet, but still would be interested in joining the program, please have that chat. Like I mentioned earlier, that 80% test used for client testing, if you want to negotiate that benchmark with me, really happy to have that conversation. I think one of the benefits of this new program moving forward is that we're really reducing, I suppose, those kind of really strict requirements. We really want to leave it up to services to decide how they want to use the test and how it's going to fit into their structure, and where we just want to be really here to support that for you ultimately, because you guys are the ones who are doing the testing, and really we want to reduce the burden on everyone, but certainly you guys, particularly the regional and remote crew, because you've got so much to do, and we really just want to make sure that people are out there doing the testing rather than trying to meet other requirements or doing other things as well. I've shown this quite a couple of times, but I love it every time because I think it really demonstrates the usefulness of point of care testing out in community, and how I think it is a really, really impactful tool, particularly in the syphilis response. But I am aware I've talked so much. I think I've only got 15 minutes left scheduled for the VC, so I thought I'd open it up to people in the room, particularly like enrolled services and interested services who aren't enrolled in the program. Does anyone have any questions about the program, or how it might look in your service, or if something isn't clear about the requirements moving ahead, if you want to have that discussion as a group, please, now is the opportunity to raise your hand. And if the solution might not just come from us here, it might come from someone else in the room as well. Tanya.
Sorry, I'm a pest today, aren't I?
There's never a pest.
No, I just wanted to know, will the reporting requirements change in terms of the point of care data collection, or will it all be part of will that be the same, essentially?
That'll be the same. So the requirements around kind of the demographical data for testing will be the same. That'll stay the same. It'll just be that you will submit the invoice as well and just note what days you use that stock, so that way we can compare it to your testing data to determine that percentage used for client testing. So that would be the only difference, is that you put the invoice in.
Yeah.
Yeah.
And is the amount, I'm assuming that 80%, the other 20% is to account for training of staff.
Training of staff, a bit of a stopgap if you sometimes get expired. You know, again, like I said, if we've got a new service, and that's kind of part of the flexibility, if you've got a new service and you say you're going to train up, 50 staff members, and you order a pack of 100 and only 50% got used for client testing, but I can clearly see, the rest of it's gone.
Yeah,
to
absolutely.
Testing clients. So it's really for that real flexibility there.
Yeah. Thanks, mate.
No worries. Anyone else have any questions about the program moving forward, particularly in a group context? Hi, Daniel.
I might have missed it at the start. Sorry, I was a little bit late. But are there sort of opportunities to sort of scale it up and to take it to additional services?
Yeah, sorry, that's another big change to the program as well. I should have added. So currently the program is capped at 24 hub sites. Now from July 1st, we won't have that cap, which is really good, because I think for last year, Matt and Caitlin have been juggling between 21 to 23 services, and we've had interested services, and we had to contact services to be like, hello, are you still interested? Would you like to unenroll to create more space? Has been one of the issues in the current program, is juggling that enrolment. So now moving ahead, we won't have a gap unless we suddenly get an explosion of services that I've got to potentially manage invoicing for. We might review, but at this stage, I haven't put a cap on number of services to be part of the program. So it's any health service in WA can sign up for it.
We're hoping that removing a lot of these barriers too will encourage services to give it a go, because now we have that availability to give it a go. If it doesn't work, it doesn't work. It's not such a massive administrative burden. So
yeah, that's another good point. And I think as well, previously services have wanted to join up, but the current requirements or the previous requirements have been such a barrier. I know a number of maternity services and metro EDs have said that they just can't commit to the requirements as they are because of this burden on their staff. But moving ahead, I've been emailing a bunch of people like, hello, it's changing, like, would you be interested now, or would you just like to have a chat about this further? So I think we'll see an influx of services who would use this, who otherwise wouldn't use it. Yeah.
And we would really encouraging individual services, if any of the requirements are a barrier, because we're aware that every service across WA is so entirely different. We don't want it to be a look at the requirements and no, we can't fit that. We want it to be a conversation and we can adapt to suit individual needs. Yeah, and there's a section in the new enrollment form where we'll note any changes to those requirements, like if it is, I don't know, for example, like if that percentage target needs to change in there for whatever reason, we'll note it in there, or how you're going to embed it into service delivery, we can note it in there, all that kind of stuff. So it's clear for everyone, clear for the service and clear for us what the responsibilities are and how that's changed as well. So, yeah.
Amazing. Great presentation. Thank you.
Thank you.
Aggie has a question. Will Flinders still provide support for multiple invalid results?
No, they won't. But we're speaking to Abbott's to look at the support they can offer for invalid results. But happy for people to contact me if they're having multiple invalid results, then we can go from there. Is that something that services have been experiencing very much? Great. Aggie, do you want to, as the person who asked that, do you want to bump in on that?
Yeah, look, to be honest, I was just kind of trying to tease out how much involvement Flinders would have, and I don't know. I feel personally, I'm not sure how this is all sitting with me. You know, if I was using equipment, I'd actually really like to know whether the equipment was working as it should be. So yeah, maybe it's just my head.
Yeah, fair enough. I suppose to answer your question, so the work that Flinders is going to be doing is stopping the 30th of June. So so 1st of July 1st of July beyond. I want to be clear, in the WA program, not the NATO program. In the WA program, they won't be providing that support. But I do want to say, Aggie, like, it is a very simple test. There are the other measures around, you know, whole chain, the cleaning and serology at the same time, the point of care test, all that kind of stuff. And I think on the note of the invalids, I think there's been very few invalids over the lifetime of the program. I know I looked at it quite recently. I should have had it good to go for this presentation, but it was minimal compared to the number of client tests that have been done.
Donna, we'd love you to weigh in if you're available to do so.
Yeah, okay. So this test is a lateral flow test, and under the Commonwealth's national guidelines about point of care testing, it is classified in the same category as a pregnancy test. So I think we needn't be overly concerned about how complex the test is and how hard it is to do, and the amount of quality control that's required for it. We need to think more about how to expand the testing to reach more people and more services so that we can get on top of the syphilis outbreak. So if you think about the amount of training that you would give an average staff member to do a pregnancy test, then you should be thinking that this is the same for this syphilis point of care testing. The only difference being that you would need to follow it up with a blood test. But that's pretty much the same as for a pregnancy test too. You know, if someone was, you know, concerned that they were pregnant and you do a pregnancy test on them, and, you know, you would probably always do a blood beta HCG on them as well. And the test specifications for the temperature that it can live in, it's quite a wide range of temperatures that it works in. So again, I don't think we need to be, you know, too worried about having to keep them in fridges and things like that. I can't remember off the top of my head what it is. If you do the PowerPoint, you know, the training PowerPoint that's provided by Abbott, it gives you all that information, but, you know, it's quite a wide temperature range, which, you know, in your average clinic, you're going to be fine. And I don't see people running around, you know, with temperature loggers on their pregnancy tests.
Thanks, Donna. Does anyone else have any questions about the WA program moving forward that you want to have a chat about in the room?
We're also happy to take questions offline.
Yeah.
People would prefer not to discuss.
I was going to say, if it's particularly about your service and your delivery and how it's going to implement in your service, I'm more than happy to have a yarn over phone, email, Teams, coffee outside of the session here as well.
I'll pop your email in the chat.
Thank you. But I get a sense that maybe we've kind of naturally reached the end of the session. Thank you so much, everyone, for coming. Hopefully this was really useful information for both interested services who are enrolled, but also the currently enrolled services about the changes to come. You will be getting information. If you're currently enrolled, you will be getting the new feedback, or the new enrolment form, I should say, sorry, from me soon to fill out and consider. But for interested services as well, please get in contact if you want to join up. I'm happy to have a meeting and a yarn about the program and how it might fit into your service delivery moving ahead. But thank you, everyone.
Thank you. Thanks, guys.
Thanks, Stephen and team.
Thanks.
Thank you. Thank you.